patellofemoral joint. Patellofemoral joint. So pretty much straight, right? Okay, good, excellent. If that's the open pack position, but now we're doing mobilizations for increase in range of motion, and so we can move out of that open pack position when we're actually trying to do a treatment intervention. Okay. So one thing we typically, and I typically do, is I might try to put a little pillow or a bolster underneath their knee just to give it a little bit of flexion itself. As far as your four directions, you have medial, superior, inferior glides. Just try to relax your leg as much as possible. Yeah, you might need to lay back. That's better. Okay. Try to get the femoral condyles level. If he's externally or internally rotated, now the joint is at an angle. It's a little bit hard. I'd have to change my hand position to be in line with that. So the first thing you want to make sure is that the person's leg is as close to being level as possible. So I might even, just to prevent his external rotation, I'll put this out to the side here. So now I feel comfortable that he's straight up and down. Superior glides, you're just gonna, best way to do it, try to get your whole arm in the direction of movement that you want. I'm going to cradle around the inferior borders, the medial and lateral inferior borders of the patella. The other thing I do with my opposite hand, I try to protect the patella from gliding, especially laterally. Which direction do patella dislocations occur? Lateral. So I just use my other hand kind of as a protective, especially with the thumb, to prevent any type of lateral excursion that may happen. And the other thing I'm trying to do also is try to stabilize the femur here. And then what I'm doing is I'm just going to apply a superiorly directed force. Okay, I can find where his end range is and then move into that new range of motion and hold it there. That would be the Kaltenborn. Okay. Is this plugged in? No. Yes, it is. Okay, good. My body mechanics wasn't great because it's a little low, but happily I have a table that I can adjust. A lot of times I'll do these sitting down too with individuals. You know. So that's going to be your superior glide. Okay, inferior glide, we're just going to do the opposite. I can come over the top. I rest my hand basically right along the thigh because his patellofemoral joint is facing that way, and then what I can do is I can find the end range of the motion and then go right into the mobilization force. Hold it there, 15, 20 seconds. We need at least 8 seconds if we're going to deform collagen, right? But we can hold longer than that. As far as medial and lateral glides, I place palm of my hand along the medial border of the patella. I try to stabilize again the femur from internally or externally rotating, and once again I can go into the medial glide. Okay. What about lateral glides? What did I say is the most commonly dislocated position? Lateral glide. So I would be pushing right into that. I'll tell you, even when I assess the mobility of the patella, typically what you're going to find is lateral glides are generally at least normal, if not hypermobile. Just for completeness of doing all the directions. No, they're going to stay up. If I'm going to do a lateral glide, I actually come to the opposite side, so now I'd rather push than try to pull the patella towards me. I'd rather push it. I can do the lateral glide. I'll tell you, this is not something I generally do at all. I just let it be, because if it is even a little tight on this side, good, maybe they're at less risk of developing a patella dislocation at some other time in their life. So those are the 4 mobilizations. The other thing that you can try to do is with varying degrees of knee flexion, you can try to do, in particular if I think flexions, the limitation in flexions due to the patellofemoral joint, I can try to bring them up into higher levels of flexion. There is a trade-off though. What happens to the patella as we go into more and more degrees of flexion? It goes down and into the femur, and so what's the closed pack position for the patellofemoral joint? Full flexion, right? Because it's all so the more and more degrees of flexion I get, the less mobility passively I'm probably going to get. So this is not something that I usually do way into end range of motion, and then I'm trying to do an inferior glide of his patella. But I will sometimes, if I feel like I'm getting a good mobilization on the joint, as long as I can feel it moving, I can have them up a little bit higher. I have to watch where the femur is in line with the patella, because that's my new direction now. All right? The femur is the concave surface, so it's the treatment plane. No. reverse that, the patella is the concave surface, so it's the treatment plane. But as it's going around the femur, its angle changes, where it was very flat when his knee's extended. As he's bending his knee, the patella's inferiorly glided and allowed to come in this direction. So the more and more degrees of flexion I have to get in that line, and I can do the mobilizations there as well. So you can play with that. He's going to slip right off of this. I would need something better than this for if I wanted to do this as a mobilization. So that's the patellofemoral joint. Okay? Tibiofemoral joint. Moving on. Sorry about that.
There you go. Let's go a little further so I can.
Let's talk posterior glides first. Posterior glides are better for flexion, and there's a lot more variations that can be done. Probably the one I like the best, if a person just had a knee replacement or an ACL, I wouldn't say just had an ACL, but let's say that, you know, status post-surgery and we're thinking mobilizations for this person, I can find that end range of movement, say it's limited right there for him. I back off a little bit, I can place the foot down. The treatment plane's the tibia, correct? So I can just stabilize them here, get my forearm in line and parallel with the tibia, and this is probably still a little bit high for me. And so from this position right here, I can go right into the posterior glide, find the end range, go into it, and then hold.
You said this was for TKA as well, or just ACL?
You can use anyone who with a capsular hypomobility of the knee that's limited in posterior glide. It could be for any condition. I would not do this if the person was 1 week knee replacement because they have staples in it, right? So, you know, with regard to their stage of healing and where they are, we'll do these or not. So this is one way to do a posterior glide, and all varying degrees of flexion. The more he's flexed, the more the tibial condyles become flatter, so my plane of motion has to change with that, okay? The more extended he is, if he's more out here, then my direction of movement needs to be more inferior here, or to the ground, I should say, posterior. Okay. Lay on your stomach for me. Another way that can be done for posterior glides is prone. Because again, we're in treatment now, so I can find his end range of motion, back off a little bit. What I like to do for myself is I will place their leg, their tibia on my shoulder. I typically use both hands around the tibia, and now I don't have to stabilize the femur so much because he's going to stabilize it himself, and I can just do a pure posterior glide and hold that there. Now what I'm not doing is I'm not trying to torque him over with my shoulder. This is just supporting, and then as I push forward, my whole body goes forward with it. So he's just getting that pure glide. I'm not trying to create a counter force or anything like that with this, okay? And again, the more and more degrees of flexion he gets into, then I have to watch where the tibia is. If he's in more end ranges of flexion, then instead of just being straight back, I almost have to go, you know, slightly anterior here because of that's just the direction where the tibia is, okay? So that's good for, especially when people are in that 90 to 100 range of motion and you're trying to do posterior glides. It's a good position, okay? Anterior glides. Flip over on your back. Again,
You're good.
I just want to show you guys this. If I'm going to do an anterior glide of his tibia on his femur, do we have a pillow that I can just borrow real quick? No. I could do it here, but what's the downside of me doing it here? If he's in supine, what do I have to do to the tibia? I have to go against gravity, and I have to actually lift it, and you hate doing that, right? It's very tiring. You can put your leg down. So if he's in this range of motion, and this is for extension, so we're probably near end range. It's going to be the ideal place where we want to be, unless he's that limited, but I've never seen anyone that limited before. So typically in this range of motion, I can stabilize the femur with my stabilization hand, have my hand, and then do the anterior glide this way. I have to hold it for 8 to 15 seconds. I have to apply enough force. So that's hard, and that will get you very tired very quickly. So really one of the best ways to do anterior glides is, once again, I need you on your stomach, but what I need you to do is I need you to slide all the way down. So we let the leg keep coming. Right, that's perfect right there. We can let the leg come down to the point where just the kneecap is slightly off the edge of the table. We don't want to push that into the table, but now I can be here and let the table be my stabilizer. And now I can see where's the end range of motion, back off a little bit. The treatment plane's, once again, the tibia, because it's the concave surface, and then, again, just go into that anterior glide. This is probably the very best way to do it. What does the person have to be able to do, though, in order to do it this way?
Lie on their stomach.
Yeah, they need to be able to lay on their stomach, so they need to be able to tolerate